Hello everyone, my name's Stephen Lee. I'm a gynecologist at the Obstetrics and Gynecology Consulting Group. Today I'm going to be providing you an update on the diagnosis and management of polycystic ovarian syndrome. So why do we need to know about polycystic ovarian syndrome? The number one reason is that the guidelines for the diagnosis and management of polycystic ovarian syndrome has recently been updated in 2018. The work was led by a group of academics from Monash University, and it makes this new guideline uniquely Australian, so we should know about it at least a little bit. Polycystic ovarian syndrome creates diverse features such as reproductive, metabolic, and psychological implications. It is very common. It affects 8 to 13% of reproductively aged women, and 70% of these women go around undiagnosed. In high-risk populations such as our Indigenous Australians, the complications rates are even higher, and these are the reasons why we need to know about polycystic ovarian syndrome. The features of polycystic ovarian syndrome. Psychologically, polycystic ovarian syndrome creates higher risks of anxiety, depression, and distorted body image. From a reproductive perspective, it leads to irregular menstrual cycles, hirsutism and hyperandrogenism, infertility due to anovulation, pregnancy complications such as gestational diabetes and increased rates of miscarriage, and endometrial hyperplasia as well as cancer. Metabolically, PCOS can lead to increased insulin resistance, leading to pre-diabetes, type 2 diabetes, as well as gestational diabetes. It is also associated with metabolic syndrome, cardiovascular disease, and obstructive sleep apnea. So what's new in the diagnosis of polycystic ovarian syndrome? There isn't a lot, but there has been some tweaks. Ultrasound is no longer recommended in adolescents. So less than 8 years from their menarche, we shouldn't be performing ultrasound because of the increased risk of multifollicular ovaries. So we just need to use the tighter criteria in terms of hyperandrogenism and irregular cycles. We also really encourage the exclusion of thyroid disease by measuring thyroid stimulating hormone levels, and hyperprolactinemia by doing serum prolactin. And we should also exclude non-classic congenital adrenal hyperplasia by doing 17-hydroxyprogesterone. If the patient is amenorrheic or has severe clinical features, the recommendation is to exclude hypogonadotropic hypogonadism, Cushing's disease, and androgen-producing tumors. AMH has been showing a lot of promise in the diagnosis of polycystic ovarian syndrome, but it has not yet been validated, so we shouldn't be using this test just yet. There's been an update in the definition of irregular menstrual cycles, and it is a little bit complicated, but once you familiarize yourself, it's not that difficult. From menarche to 1 year post-menarche, women can have very irregular cycles, so we can't really diagnose someone with irregular menstrual cycles in this time period. From 1 to 3 years post-menarche, irregular menstrual cycle is defined as less than 21 days or greater than 45 days apart. Greater than 3 years post-menarche to perimenopause, irregular menstrual cycles is defined as less than 21 days apart, or greater than 35 days apart, or less than 8 cycles per year. If at any point after 1 year post-menarche, they're having more than 90 days between periods, that's also considered irregular menstrual cycle. If they have primary amenorrhea by the age of 15, or greater than 3 years post-thelarche or breast development, that's also considered irregular menstrual cycle. When they have irregular menstrual cycle, a diagnosis of polycystic ovarian syndrome should be considered and assessed. For adolescents who have features of PCOS but do not meet strict criteria, then they should be considered at risk, and a reassessment should be done at 8 years after menarche. So in terms of hyperandrogenism, to assess for clinical hyperandrogenism, we should do a thorough examination and history taking for acne, alopecia, and hirsutism. In terms of scoring hirsutism, standardized visual scales are preferred, such as the modified Ferriman-Galway score, which I'll show you in the next slide. In terms of biochemical hyperandrogenism, tests that are recommended include calculated free testosterone, free androgen index, or calculated bioavailable testosterone. Androstenedione, or DHEAS, which a lot of us order, should only be done if total or free androgen is normal. And it is important to note that reliable assessment of biochemical hyperandrogenism is not possible in women on the pill. This is a slide of the modified Ferriman-Galway score, and greater than or equal to 4 to 6 is considered hirsute. In terms of ultrasound and polycystic ovarian morphology, the ultrasound should not be used in the assessment of PCOS in adolescents due to the increased prevalence of multifollicular ovaries in this population. When we're using transvaginal ultrasound, we now use the follicle number of greater than 20 or the ovarian volume of greater than 10 mils as the cutoff. If we're using older technology, or if a patient is having transabdominal ultrasound, then we look at the ovarian volume of greater than 10 mils. Because all women with polycystic ovarian syndrome are at increased risk of cardiovascular disease, they should have regular monitoring of their weight and blood pressure. All women with PCOS should be assessed for cardiovascular risk factors such as obesity, cigarette smoking, dyslipidemia, hypertension, impaired glucose tolerance, and lack of exercise. Overweight and obese women with PCOS should have a fasting lipid profile. In terms of impaired glucose tolerance and diabetes, all women with PCOS should have baseline glycemic index status tested, either by OGTT, fasting plasma glucose, or HbA1c. In high-risk women, and these are the ones who have increased BMI or have history of impaired glucose tolerance or gestational diabetes, or a family history of type 2 diabetes or hypertension or high-risk ethnicity, they should have an OGTT. Other health implications of PCOS include obstructive sleep apnea, endometrial hyperplasia and cancer, anxiety and depression, and psychosocial dysfunction. These patients with PCOS should undergo at least some sort of screening and further testing if appropriate. Just very quickly on interventions for PCOS, the first line is always lifestyle modification. What we recommend is that you counsel them about healthy eating and refer them to a dietitian if it is appropriate. They should also have encouragement to to increase their physical activity. The recommendation is 150 minutes per week of moderate activity or greater than 75 minutes per week of rigorous activity. They should consider a weight loss goal of 5 to 10% in 6 months, particularly if they're overweight or obese, and these patients should come back regularly for monitoring of their weight. All patients with PCOS should be considered for the combined pill, particularly if they require contraception, if they have hyperandrogenism, or if they have irregular cycles. What we should do is aim for the lowest effective estrogen dosage. Metformin should be added to combined oral contraceptive pills if lifestyle interventions don't achieve desired goals in terms of their weight or hormonal goals. Anti-androgenisms such as spironolactone can then be added if the hyperandrogenism symptoms continue after 6 months of combined pills, or if the combined pill is contraindicated, if their cosmetic interventions that the patients have chosen to do have failed, or you can go straight on to anti-androgens if they have alopecia. That's the conclusion of my talk. Thank you for your time, and thank you.